So Asians have a particular body type in which they have a lot of truncal obesity, central obesity.
Central obesity, which leads to diabetes as well as dyslipidemia. Big tummy, and we used to call them sahukar or landlord. But that has become a kind of sin nowadays. I'd learned or seen many videos, intermittent fasting. Your nature says you need to eat at particular hours to generate the energy. If you don't eat, body tries to make it, but how? It's in total different mechanism which is more damaging to the body. People don't understand that.
Hi guys. So we have created a series of podcasts to raise awareness. Awareness about what? Awareness about brain stroke. And why? That's because globally, brain stroke is the commonest cause of morbidity, and especially so in Southeast Asian countries like India, where the stroke burden is the highest. And as a matter of fact, it is very concerning also because it is affecting youngsters. And as you guys know, youngsters are the backbone of this country. So we have invited various medical experts, neurologists, neurosurgeons, cardiologists, ophthalmologists, radiologists, to talk about brain stroke and give their vital piece of information, their perspective regarding the same. Now, this whole campaign is being created by a charitable organization called as Purva Medical Trust. And the name of this project is Project Brain Line. Now, the main aim of Project Brain Line is to create awareness about brain stroke and to create a network of primary stroke care centers throughout the country so that they can respond to stroke and they can treat stroke in the best possible way in the fastest time. And also, from this whole campaign, you will get the vital information necessary to prevent stroke in the first place. And that's why I hope you guys find these series of podcasts valuable, practical, and useful in your daily life. And I hope you guys give us your valuable support. Thank you. Okay, so आज के जो हमारे गेस्ट है वो है डॉक्टर अतुल इंगले. नाउ ही इज़ अ नेफ्रोलॉजिस्ट and he is the winner of Vikas Ratna Shiromani Award, Indian Gold Achiever Award, Health Icon Award. So बहुत सारे awards मिले हैं. Outside of his medical world, he is a race car driver. He is a sports enthusiast. Badminton खेलते हैं, cricket खेलते हैं. So an overall very happy personality. अभी इनसे हम सीखने वाले हैं कि किडनी का क्या फंक्शन है ओवरऑल हेल्थ में और स्ट्रोक में. क्योंकि हम हार्ट के बारे में तो बहुत सारी इन्फॉर्मेशन हमारे पास है, ब्रेन के बारे में बहुत सारी इन्फॉर्मेशन है, लेकिन किडनी ऑफन ओवरलुक हो जाता है. इसके लिए इस पॉडकास्ट में एकदम डिटेल डिस्कशन हुआ है एंड उस पूरे चीज़ को समझने के लिए इस वीडियो को एंड तक देखिए. आई होप you derive a lot of information, lot of value, and you have fun listening to the podcast. Thank you. So let's start from the beginning. Now you are nephrologist. So can you tell us what exactly do you cater to, or is the specialty related to exactly? So for the common people, what is nephrology?
See, basically, many Greek terminologies are inducted or into it in the medicine. That is if you see kidney, it never stuff, I can call it filtering corners or exhaust system of the pulse. It has to filter out all bloods or toxins in the body in the form of urine. A kidney, when I say it's a filter, it's like a T-net. Because the function is yours. The impure blood comes, impurities falls, and the pure blood passes out. And that functioning unit or filter is known as nephron. So from there it became nephrology, means kidney related. This is the called that. There are almost 2 to 2.4 billion nephrons in both the places. So that will count is the nephrology term that will coin means related to the kidney disease. The The kidney diseases, the format is changing over the period. For example, when we were students, kidney disease means glomerulonephritis. A glomerulus is the uppermost phreatic area of the nephron. When that gets affected, inflammation, itis. That is glomerulonephritis. So, glomerulonephritis. Then that collecting system is called the tubule. And the area surrounding that tubule is a interstitial. So, tubular testicial nephritis. It's when the primary kidney diseases that stoat formation. The stoat formation anywhere from ovary to bladder or a generic gland is known as nephrolithiasis.
Lithiasis means stokes.
Nephro is related to failure. Then malignancies, then genetic diseases like forest. So these are the cohort diseases. Okay. Slowly, then I did nephrology from Lasses Busam Latron in that area, and the whole process started changing. Like for a couple of weeks, for us during MD Parisi days, heart problem, diabetes, hypertension were related to 60s, they were given what? 6 ticket or 7 ticket. But 94, they started shifting toward the younger side.
So they started having kidney cockets.
Have were not detected. Why not detected? Because the definitions of kidney problem was not uniform. The basic, now coming to apart from diseases, there is pulmonary, like kidney failure. There were two types of kidney failure described for. Acute renal failure, okay, the term renal. Chronic renal failure. Now, what is the basic difference between this acute and chronic? Acute is most of the time reversible. Almost 90 to 100% recovery is possible. Chronic, there is more. Second most important point is that many times you get radiological confirmation. In chronic, you get a smaller size stick. The kidney size normally is like the fist, 10 centimeters. Anything below 10 centimeters, this sticker has a small diameter structure. That KPN na proper, so maybe genetic right of birth, maybe later on with the scar, some water. But scar or the small size kidney is a bit considered as a clotted.
So, sir, when we are saying acute kidney failure and chronic kidney failure, so is there a difference in time, as in acute renal failure will happen for a short duration of time and chronic renal failure will happen over a period of time? Is it something like that?
It's absolutely true what you say. Because acute kidney failure develops few hours to few days, while chronic takes few weeks to months. So that's a time duration. But you can't pick it up. It's very difficult to pick it up when it started, unless and until you get the symptoms. That is another point to why kidney gets neglected. Because there are no symptoms most of the time. If it's an acute infection, you'll get the symptom. If it's an obstruction like a stone, then you will get a flank pain symptoms. Fine. But by the time you get signs of kidney failure like swelling, edema, nausea, vomiting, loss of appetite, or something like altered sensorium, means you start sleeping more, drowsiness, loss of some memory. These signs will come only when kidney has decline in its function for a longer time.
So after the damage has been done.
Almost to the tune of 80-90% plus. So most of the kidney diseases means kidney failure are missed out. Now another problem was definition problem. For chronic renal failure, the definition was not uniform. It was something like an elephant described by blind men. Different definition in different parts of world. So in order to bring uniformity, 2001 National Kidney Foundation of USA formed a group, and this is known as KDOKI group. KDOKI group is a very popular group, consists of 120 nephrologists all over the globe that time. I was part and parcel of that. And they coined the term CKD, chronic kidney disease for chronic renal failure or chronic kidney failure. Now, CKD, chronic kidney disease, has been divided into 5 stages. I won't go into the details about that, but there are 5 stages. Last stage is end-stage renal disease or end-stage kidney failure. That means you require either dialysis or transplant for the survival. Now, the definition also for CKD has been made very simple, related to the structural or functional abnormality which remains there for more than 3 months. Very simple definition. You can pick it up on routine executive health checkup plan also.
Okay.
If you are finding something suspicious in the urine testing or the blood testing which is related to the kidney, you get suspicious. Naturally, you keep on following the patient regularly. If it persists for more than 3 months, it is called as chronic kidney disease. Then later on, even definition of acute renal failure also changed in 2007. But this time the body is KDCO. Because KDCO is an advanced stage of KDOC, you can say. They coined the term acute kidney injury. Because how to define acute kidney failure or acute renal failure? Again, there was a controversy. Means I can say, I always give an example to the audience, means medicos, that Ravan had only 10 faces. But acute renal failure had 135 faces, means 135 definitions. That has been coined to one single line. And these are the staging depending upon the urine output per hour and the rise in serum creatinine. Okay, so, we'll keep that apart. But this is the difference between acute kidney injury and chronic kidney disease. One more important point I would like to highlight over here. Most of the time before was that creatinine was taken as a criteria for the kidney function.
Okay.
Now, all over the India, the average upper level of creatinine is 1.3 or 1.4. Around 1.6 or 1.7, doctor used to think, it's a 0.2 decimal difference, hardly makes any difference, its kidney function is okay, neglect it. No, dear friends, it crosses 1.4 means straight away both the kidneys function is down by 50%. Why? Because you need to calculate filtration rate of the kidney, that is known as GFR, glomerular filtration rate. What we calculate with the ready-made calculators, or we use the formula known as CKD API formula, which is a gold standard for the measurement of GFR, that is EGFR, estimated
EGFR.
So, it takes into account gender, age, creatinine and ethnicity. This formula has been coined accordingly. And this gives you exact estimation of the GFR, EGFR. And according to that, then you can classify the stages of CKD or you can define the functioning of the kidney.
So what you're saying is whenever somebody does their kidney function test, so creatinine is not the only thing you have to look at. You have to also look at the EGFR.
Yes. Nowadays, it's a standard protocol by any laboratories in India. They are mentioning EGFR in the record.
Right.
So they are not only mentioning creatinine, but they are mentioning EGFR also.
Right.
Another factor one should look for the kidney problem is urine routine examination and urine albumin upon creatinine ratio.
Okay.
Or what we call it as a albuminuria, loss of protein in the urine. Also, there is the entity known as UPCR, urinary protein creatinine ratio, or proteinuria. But for a layman, albuminuria and proteinuria should be one and the same thing. That means it's a loss of protein in the urine.
So there are some proteins going in your urine.
Yeah, and that indicates injury to the filter. That is the first sign of kidney injury most of the time.
So a lot of our audiences are health conscious. They like to work out a lot. They like to consume protein a lot. So does consumption of more amount of protein lead to proteinuria or proteins in urine? Can it happen?
Yes. See, I won't agree about by increasing protein intake, whether in the form of non-vegetarian diet or special protein powder, that will lead to rise in protein in the urine, that is proteinuria. No. But
Okay.
definitely it may increase the creatine level.
Okay.
you are burdening the kidney. And our the K-DOCI and K-DIGO guidelines has mentioned, taking into account the meta-analysis, the persons who consumes lot of non-vegetarian diet, that's a risk factor for developing chronic kidney disease.
So, but what is that lot of protein? As in, somewhere it was recommended that if you search on the internet, you'll see many places where it is recommended that you should consume 1 gram of protein per kilogram. And if a person weighs 90 kilograms or 100 kilograms, that's 100 grams of protein in a day. So that is a huge amount. So will that put a stress on the kidney?
See,
Because that amount is
don't you think 90 kg person, you have to take into account BMI now, height also.
Okay.
It is short.
Mm.
With 90 kg, that means he is obese. So calculation is going to go wrong.
Okay.
But a same person who is 6'2", 6'3",
Mm.
weight is around 90 is fine. Then 90 grams of protein is okay.
Is okay.
You have to take into account the body surface area also, not only the weight.
The muscle percentage, the fat percentage.
Exactly.
And according to that, you have to consume protein.
Exactly.
So, if you adjust your protein intake according to that and work out, then it will help in muscle building and it won't cause a stress on your kidney. Because people tend to do that for a long period of time. People are into health. So they make it like their lifestyle that I'm going to work out and then I'm going to consume protein. And this has been going on for years.
I can explain it in very simple format. I am very fond of cars,
Right.
Suppose take a small car, family car, which is supposed to carry 4 passengers. Now you dump 2 families and use that car regularly for over the period of 6 months or 1 year. Whether there would be wear and tear or not.
More wear and tear than...
Because it has been loaded. It has been used beyond its capacity. Same thing happens if you consume more proteins over to your kidney. There is more increased renal plasma flow, increased filtration. So it's going to burn out your kidney. You got my point?
Right. And so this question was regarding all those health freaks. But the main topic for discussion for this podcast is how is kidney related to heart? How is kidney related to brain? Stroke. So how does that happen? What is the connection between these organs?
Sometime back I mentioned CKM syndrome. Now let's go to little bit the basics. Consider stroke is a top end of the pyramid and all the entities are at the base. So at the base what? Suppose for example you take a case patient of CKD, kidney patient. Is he vulnerable for heart problems or brain problems? That is what is your question. They are highly vulnerable.
Okay.
Why? As per the data, even guidelines says that if you compare kidney patient population and the general population, the kidney population or kidney disease population is very, very highly risk for cardiovascular disease and the cerebrovascular disease. Okay?
Okay.
You'll be finding it funny if you take death rate, mortality of end-stage renal disease, last stage of CKD, who requires dialysis and a transplant for survival. You know what they die because of? What is the number 1 cause? Cardiovascular disease.
Okay.
And number 2 cause is stroke.
So if the kidney is not functioning properly, the number 1 cause of death
Is cardiovascular disease.
Cardiovascular disease.
Followed by cerebrovascular disease.
So problem in heart and problem in brain.
And they never die because of kidney.
Right.
So that is a gimmick, but yes, that is a reality. So to answer your question, basically everything starts from so-called terminology. What we use is atherosclerosis, damage to the blood vessel because of bad and good cholesterol imbalance.
Okay.
Okay. Fancy names has been given to diagnose them. like metabolic syndrome. Metabolic syndrome means abnormal triglyceride level, abnormal HDL level, abnormal sugars, blood pressure is abnormal, and of course BMI and all that abnormality. That is metabolic syndrome. For CKM, they have made very stringent rules. If I go into the details of CKM, because this is going to take care of your metabolic factors, your heart, your kidney, and your brain, because they are interlinked.
They are interlinked, yeah.
So, what I feel, if you diagnose CKM syndrome at the earlier and start treating them, not only you prevent cardiac problems, not only you prevent renal or kidney problems, but you will prevent cerebrovascular accidents also.
Right.
Okay? And the rules and regulations for the CKM to define stage 0 means you are normal.
Okay.
No increased BMI, no obesity, no blood pressure, no kidney problem, no cardiac problem.
So there are these various criteria on the basis of which we can decide the staging.
Yes.
Like you mentioned, BMI. So if the person is overweight or obese, or if the person is having blood pressure. So whenever we want to see what stage the person is at. So basically, why are we doing staging? To assess how much is that person at risk
Absolutely.
of developing all these other events, like a heart problem or a brain problem. So it's like cancer staging. So
Agree.
if we are able to stage a person and find out the risk, we can take appropriate action, appropriate measures.
Absolutely.
So this staging, again, this like for the people who are listening to this, so they need to understand that how does this staging come? So this staging will come based on various factors like your BMI, your blood pressure. So if your BMI is high, your perhaps the total score will get 1 point. And based, if your blood pressure is high, it will add another point. And based on the number of points, the stage will be decided. Is it that way?
Basically, it is not based on the point system.
Okay.
It is based on the parameters.
Okay.
As I said, stage 0. They have purposefully kept stage 0. That means everything has to be normal. As I told you, blood pressure, metabolic factors like lipids and all that, no obesity, no dysfunctional adipose tissue. Of course, kidney function is normal and heart function is normal. So everything is goody-goody or normal.
Okay.
Stage 1. The most important is BMI and waist circumference.
Waist circumference.
Yes. And dysfunctional adiposity. Now,
Right.
repeatedly I am using this word dysfunctional adiposity. It is not complicated term at all. Dysfunctional adiposity means simply for layman it should be diabetes.
Okay.
This tummy or truncal obesity is a dysfunctional adiposity. So, rules for a Westerners are different, Asians are different for CKM. For example, BMI. BMI more than 25 is taken as obesity for CKM Westerners. You know what is that level for Asian? 23.
Right.
They are very stringent. Waist circumference. 90 centimeter for a male is normal for Westerners, or above 90 is taken as truncal obesity. For Asians, it is 80 centimeter for males.
So, but sir, why are these criteria so stringent for us? How are we different from Westerners that
It's probably a genetic problem.
way? Okay. So we are not allowed to be as high on the BMI scale as they are probably allowed to be.
If you look at the BMI level, they are matching most of the time. But you know, for Westerners, it's a evenly distributed fat.
Right. Okay.
Have
Right.
you
Right.
observed?
Right. Right.
Asians
Right.
and particularly Indians. And gone are the days, but big tummy, and we used to call them sahukar or landlord.
Uh-huh.
But that has become a kind of sin nowadays.
So Asians have a particular body type in which they have a lot of truncal obesity, central obesity,
Frontal obesity, which leads to diabetes as well as dyslipidemia.
which the Westerners don't have, and that is why the criteria are different.
Criteria for different.
Okay.
Now stage 2. Where comes metabolic syndrome?
Okay.
Now, metabolic syndrome says that your triglycerides more than 150 are abnormal. But for CKM syndrome, more than 135 are abnormal.
Okay, sir. What is triglycerides?
Triglyceride is one of the bad cholesterol, you can say.
It's one of the bad cholesterols. Okay.
We Indians are very fond of it because on an average, Indian triglyceride levels are 400 plus. It's genetically linked.
Plus.
Yes. That is somewhat related to genes, somewhat related to diet, lack of exercise, and so-called modernization, junk food. So triglycerides is levels are the cutoff levels given. Of course, HDL is also taken into account. If it is less than 40, then that is stage 2 CKM.
And HDL is the good cholesterol. So for
That
our
is the reason I
listeners-
use terminology less than 40.
Right.
Less
So,
than 40
so
is
the
bad.
good cholesterol should be more and the bad cholesterol should be less. So while we look at our cholesterol reports, not all cholesterols are bad. Obviously, there is good cholesterol, there is bad cholesterol.
Most of the time, see, I'm a nephrologist. I'm not a very great cardiologist or neurologist who looks into depth of that. But for me, only one good cholesterol is there, that is HDL.
Right.
HDL is good, you are pretty fine. LDL, VLDL, triglyceride, or the ApoL and ApoB and all that, they're all bad.
So HDL is good. All the others are bad cholesterol.
Yes. And you won't find.
Right.
You won't find that HDL is very good and others are also others are at a bad level. No. It is always reverse. Bad are bad only, HDL is low.
Okay.
That is a common finding in India.
Right. So, okay. So, whenever we look at cholesterol reports, somebody does a routine test. So, if the cholesterol report, overall report is bad, the bad cholesterol will be high and the good cholesterol will be low. We'll never find a person in which bad cholesterol is also high, good cholesterol is also high. Invariably.
Yes.
Most of the time.
Yes.
Right.
Absolutely right.
Right. And like we spoke about cholesterol, so lipid profile, cholesterol blood test. Now, one question that I would like to ask you is that suppose we want to detect any renal disease or if anything is happening to my kidney and we do a kidney function test. What do we see in or a urine routine in which a person gives his urine and then the things are checked in that urine? So what does a layman need to look out for in those reports?
They should look out into only 3 to 4 factors. Proteins in the urine, sugar in the urine, WBCs or pus cells in the urine, RBCs in the urine.
Okay.
If this is something abnormal, they should report to their family physician or
Protein, sugar, WBC and
red blood cell.
RBC. Okay.
That is a job of a physician basically to carry forward, whether to go into the depth, find it out, what are the problems or
Right.
what may be the cause.
What is the reason that we
Investigate.
are getting all these abnormal results, right? And as far as the kidney function is concerned,
Kidney function is concerned, they should look into the blood urea nitrogen, creatinine, of course electrolytes, but electrolytes they won't understand much. And the entity which is nowadays mentioned on the reports is EGFR.
EGFR. Yeah, previously they used to mention GFR.
Now, previously they never used to mention anything about it.
Okay. So now EGFR has to be taken into account while assessing the kidney function, as in how are your kidneys doing.
So anything below 60, that should alarm the bell for them.
And you said below 60 for more than 3 months.
Below 60, report to your physician. Don't wait.
Okay. Respective of...
Then let him find out what it is.
Right, okay. Okay, so for a normal person, it can be above 60.
See, normal GFR is 120. There is a gradual falling GFR as per the age. Every decade, GFR reduces by some, for example, it may be around 3 to 4 ml.
Right, right,
Okay,
right, right, right.
that's a age-related fall in GFR. Sometimes it is fast, sometimes it is slow, depending upon the various factors. But on an average, around 90 is fine.
Around 90 is fine. So guys, whenever you look at a kidney report, okay, kidney function test, you'll see something written as creatinine, something written as EGFR. So you have to look at these two things and you have to consult your physician, ask him whether my reports are all right, because these two things are important. Now sir is saying that as age advances, your GFR will start falling slowly because of the natural fall
It's a
in
aging, na?
natural fall in kidney function. So that happens.
You can say shelf life.
Shelf
Our
life,
life
yeah,
is
yeah.
around 80 to
Right.
90 years.
Right.
So that's a shelf life. So as your age advances, each and every system or organ is going to wear it out.
Right. Yeah. So this is about kidney function, and sir is saying that if the GFR that you see in your reports, if that falls below 60, an alarm should be raised. You should consult your physician.
Absolutely true.
And what is that number for creatinine?
See, that is what I was discussing in the beginning. Don't look at the creatinine because that is misnomer kind of thing. It won't give you exact function of the kidney. But anything above 1.4, naturally GFR is going to be low even if creatinine is 1.2.
Okay.
See, creatinine values will slightly fluctuate as per the age also. Now, 1.2 is very abnormal value for a young male or young female.
Okay.
But that's okay, like for 60 plus. You understand my point of view?
Mm-hmm.
So don't look into the creatinine, primarily look into the GFR only. If you find anything below 60, better inform to your physician or take his opinion. What is to be done?
So is it that GFR is more important than creatinine?
Creatinine is an end product of body's metabolism, one of the toxins excreted by the kidney, and we take it into account for the measurement of the kidney function. Gone are the days when kidney function was totally dependent on values of creatinine. It's an indirect marker. As I told you, you calculate GFR with the help of creatinine, gender, age and ethnicity. And that GFR or estimated GFR is the exact function of the kidney.
Okay.
So don't look at the creatinine. Look at the GFR only, I would suggest. But for rough levels, anything above upper limit of normal limit is always mentioned on the right corner.
Right,
So anything
right,
above upper limit of normal should be informed to concerned authority, means he is primary family physician or physician.
So the creatinine can be, let's say, borderline, but
Yes, kidney function, I mean, GFR would be less than 60 also.
but could it be that the creatinine is borderline, but still can the GFR be normal?
No,
Okay.
GFR is calculated with the help of CKD API formula. What is one of the factor in that? Creatinine. So if creatinine is high, naturally GFR is going to be on the lower side.
No, I'm saying if it is borderline, 1.2.
That is what I said. Average cutoff in India is 1.4. But when it crosses 1.4, your kidney function is down by 50%. That means your GFR is down by 50%.
Okay.
If we have mobile, you can have ready-made calculators. Just put the values and you'll get the GFR.
So let's say, for example, somebody who works out a lot. Are we expecting the creatinine to be high in a person who consumes more amount of protein?
Yes.
But then,
And now is a glitch. That guy must be consider around 30,
okay.
consuming proteins, whatever it is. His creatine comes high. Calculate his GFR. His GFR will be low.
Okay.
If time permits, I would have shown it on the mobile how to calculate GFR. Or we can add tag on 5-minute session how to calculate GFR. It's very easy.
So that is a little bit concerning because people these days consume a lot of protein. As in, that is just because of the awareness. If you're working out, again, you have to consume a lot
my advice to these guys was don't go to extremes. You should always learn to walk on the middle path. You should not go to extreme this side or that side. Means cut down on protein, that means cut down to zero. That is also bad. Excess consumption of protein is again bad. Go optimal, na? What is required?
And sir, what is optimal for somebody who is working out regularly? What is the optimum amount?
Normal protein intake I would consider as a 1 to 2 gram per kg per day.
So that is 1 to 2 grams kg
Per kg.
per kg per day.
Yes.
But sir, 1 to 2, if you are saying, then if a person weighs 80 kgs, so that means
At that time I told you, take into account
take
height
into
and
account the BMI and the muscle mass and everything. But when we are saying, like, for the general people, 1 to 2 grams of protein per kg per day. So what is my gym bro going to do? He's just going to see his weight. Suppose it's 80 kg. And now he's going to think I should consume somewhere between 80 grams to 160 grams of protein per day. So will that be right, or will that keep the kidneys safe?
that should ideally keep kidneys safe.
Okay.
Or he should go for a proper diet which should have little bit more content of protein, lesser content of carbohydrates, and the least content of lipids, oil. For example, if you go 40, 30, 30, that is much more ideal. So in that 40%, if that 40% is lesser than your calculated protein intake, say for example 80 gram, maybe 70 gram per day, fine, no issues. Because some carbohydrates, some lipids do get converted to proteins also.
Okay.
You don't have to pump in. You are pumping in, disturbing the balance. That is the rule of the nature. Don't you agree with me? You disturb the nature and you are screwed up. If you are particularly asking me about a gym and this protein intake and all that, tell me what happens to this Mr. World and Mr. Universe? How long they live?
They really
On
have
an
to.
average 35 years, whatever I had seen. Why? Not only proteins, there are much more other intakes also.
Yeah.
Exist.
They do a lot of other things as a performance enhancing drugs and everything.
That means you should take learning from them. Their lifespan is just 30, 35. Have anyone seen what happens to them? How they die?
So
What you are trying to do by consuming excess amount of protein, are you building up muscle? No. Your muscle will build up to some level with the exercise and with the diet. Beyond particular level, no. It has to be artificial.
right.
You are not born for that. Genetically, which I cannot answer that question, but everybody, like their genetic signature is different, their genetic structure or body structure is different. Your own fingers, 5 fingers are different. How 2 persons will be same? He may develop good bodybuilder, Other, whatever he tries, it doesn't develop into that.
That is genetic.
So don't push to the limits. That would be my suggestion or advice to these bodybuilders or protein intake or gymming.
Because what they usually do is, like, if they want to live long enough, then they take an insane amount of protein for some time, for as long as they are professionally active, and some performance enhancing drugs and everything,
You
related
need to
to that.
differentiate between these categories. One is bodybuilder. Their target is to become bodybuilder or maybe kind of a hobby or passion. Okay. One group who wants to remain fit. Oh, boss, to remain fit, you need to look into the multiple factors. You eat lot of proteins, you do lot of gymming, and 5 hours a day in the evening, you go and booze. Is that going to maintain? No. You are not sleeping properly. Is that going to maintain? No. You need to reduce the stress. You don't reduce the stress, you are bound to land up in this category of CKM syndrome or landing up with any cardiac problem or neurological problem. So to maintain self, you maintain with the BMI or the waist circumference. Automatically you will be maintained with the lipids also. Because to maintain BMI, your diet is going to be proper.
Right.
Okay, I had learned or seen many videos, intermittent fasting. What the fuck? Your nature says you need to eat at particular hours to generate the energy. If you don't eat, body tries to make it, but how? It's in total different mechanism which is more damaging to the body. People don't understand that.
But
they are just losing weight and they are happy.
But sir, there has been a lot of things which have been said about intermittent fasting, as in that it is beneficial to the body and people should do intermittent fasting to lose weight. That is obviously there.
See, there is a concept in very religious beliefs also. Do fasting, you give rest to the body, digestive system. May be true. That has not been proven with the scientific data.
That's not been proven.
That's not been proved. Where it is proved, show me one study. But about the intermittent fasting or these fancy new things, you take this amount of protein, you take that amount of carbohydrates, less amount. Wherever you are going to disturb the balance, you are going to pay the price this way or that way. You know, you ask any endocrinologist, those deals with the metabolic syndrome. So naturally they deal with the cardiac patients, kidney patients and neurological patients also. Ask them, is it good to fast for longer time for any diabetic patient? No way. They ask patient to eat every 4 hours.
So, but then that might be ideal for diabetic patients because they have to regulate their sugars in a very particular way. But for someone who just wants to lose weight or improve their cardiovascular health, so improving health is not just losing weight, it's also improving your aerobic function.
I don't believe, because I haven't practiced for 35 years. 24 years back, I published very great study, because that time all the guidelines were talking about the smoking. I said, my country doesn't have many smokers but tobacco chewers, mawa, gutka and all that. Okay. So I picked up the age group of 20 to 40, literally no complaints individuals. I picked them from that tapris and all that, who used to chew tobacco. I said, I'm doing your test free.
Okay.
You know what the data revealed? 90% to 95% were positive for dyslipidemia, insulin resistance and low GFR, low kidney function.
Okay.
Why?
Because they were taking tobacco in some form.
Indian genes are very different. We are highly vulnerable because we are looking at the Westerners following Western food habits or their style. What is lacking most of the time? Proper sleep, relaxation, proper diet and no exercise. And instead of that, lot of carbohydrates, okay, lot of alcohol, fried stuff, oily, this thing, no sleep. You go to bed around 1 or 2 o'clock, get up around 7 o'clock, stress of performance, professional. How long your body is going to take it?
ओके गाइज, आपको एक रिक्वेस्ट है, आप प्लीज़ सब्सक्राइब कीजिए बिकॉज मैं और भी इंटरेस्टिंग गेस्ट्स लाने वाला हूँ एंड ये पॉडकास्ट बड़ा बड़ा बनता जाएगा, गेस्ट बड़े बड़े बनते जाएंगे, इज़ माई होप. सो आई रिक्वेस्ट यू गाइज टू प्लीज़ सब्सक्राइब, क्योंकि इससे हमको बहुत हेल्प मिलती है. एंड ये वीडियो एंड तक देखना, इसमें बहुत सारी इंटरेस्टिंग इन्फॉर्मेशन आपको दी गई है. एंड आई होप यू फाइंड वैल्यू इन दैट इन्फॉर्मेशन. सो प्लीज़ सब्सक्राइब. So, but then, so, okay, we'll go back to this things. The study that you did, that sounded very interesting. So, you picked up people
Who are having no complaints.
who were having no complaints. They did not smoke.
No, one group did eat chew tobacco, one group did not.
Okay, so you divided those people in two groups. One group chewed tobacco, one group did not. And the result that you found out in
See, in toto, if you are asking me, almost 70 to 80% dyslipidemia, abdominal obesity and low GFR.
which group?
Both.
So even if you're chewing tobacco or
Yeah.
not chewing tobacco, you're going to have that.
Now there is a difference. If you now divide the group, the people who were chewing tobacco, these abnormalities were in 98%. You can understand. So these are aggravating factors. But what I want to point finger at, we Indians are genetically Indians are susceptible to metabolic syndrome.
Right. So it's not just the aggravating factors which is going to harm you. The lifestyle we live as it is not very good.
That is what I said. Now you are adopting Western lifestyle, and that you are paying the price. So coming back to your protein intake and all that, you should. Point is very simple. Bottom line: don't exaggerate. Walk on the middle path properly.
Only take as much as required.
Why is required? And try to focus on other parameters also, like proper sleep or proper dieting, even food habits or food timings.
Food timings.
Yes. Well, they say that the best way is breakfast like a king, lunch like a rich person, and dinner like a beggar. Why? Because night time you are resting. Your body doesn't require. And what we do? Exactly opposite.
Usually
We
have
do
a
breakfast
light
like a beggar.
breakfast. Yeah.
Lunch, sometimes whatever is available, and then you hog after coming home.
At dinner. It's the usual pattern.
And the usual pattern. And this leads to metabolic factor or CKM syndrome or kidney or heart or neurological issues.
So that is why I wanted to know, if we are eating so much, so if we probably fast, if we don't eat for a certain part of the day, is it going to help us?
See, it depends on the type of person you are and the work pattern you are adopting. It varies person to person. You cannot put it as a thumbs rule.
Right, okay.
See, how many patients you will find in dysglycemia or dysfunctional adiposity? You take a age group of 30 to 40. Nowadays, everything is shifting below 30.
So dysglycemia is?
Dysglycemia,
Deranged.
dysfunctional adiposity, or impaired fasting glucose or whatever they call it.
So basically
That
sugar is high.
Step 1 diabetes, where HbA1c is 5.7 to 6.3.
Right.
Many persons are there. Every alternate person. I was going through the data of India's diabetic population. You randomly select 10 people and one will have diabetes. And if you take into account the kidney people, you catch hold of any 3 diabetics, one will have kidney problem. You catch 5 hypertensives, one will have kidney problem. The CKD is so common. Because in India, diabetes is so common, hypertension is so common. India was capital of diabetes once upon a time. Now China has taken over, but still it is number 2.
Really? I thought India is still the diabetes capital
China
now.
has taken over. India is number 2, but still it is number 2. That's what I told you. In India, even if you look around, catch 10 people, will check their blood test, one will have diabetes. And they might not be aware of it.
Also, there was, I have seen a few cases in which the kidney function deteriorates And the thing that struck me about those cases the most was that, so I had a friend, his dad had all these comorbidities, as in all these diseases, hypertension and diabetes. And as a routine activity, they used to get his all these routine tests done. What happened was he had diabetes since a long time, and since the past 1 year, of course, the kidney was affected, goes without saying. His sugar control was not that great. But up until this last year, he was doing fine. But now, suddenly, in the past few months, his kidney function has dropped rapidly. Creatine is constantly going on increasing, and now the person is getting symptoms. Now he has landed up in big trouble. Like you said, stage 5. So either the person has to do dialysis or get a kidney transplant. So I just want to say that it's very dramatic the way it starts going downhill.
Coming back to CKD or kidney diseases. Now, today's date, the biggest problem about the kidney is CKD. What is the number one cause of CKD? All over the globe or in India? Diabetes. Second is hypertension. Third is CKD-U. These are new entities, CKD of unknown etiology that I won't discuss over here, but that is there. Along with that, then comes TIN, glomerulonephritis and so on. First two are diabetes and hypertension.
So sugar and blood pressure.
Yes. And as I told you, 3 diabetics, 1 would have CKD. 5 hypertensives, 1 would have CKD. Okay? Whenever you are diagnosed to have these entities, you should go for kidney check or your physician will get it done. There was a meta-analysis published in 2014 about Asia.
So, what is meta-analysis for our people?
Meta-analysis means multiple studies.
So when you see multiple studies, when you study all those studies and then you make a report,
Yes.
that is called as a meta-analysis. Right.
What they looked into it, very simple. Doctor is diagnosing this XYZ as a diabetic, type 2 diabetes. And they're checking kidney function also that day, same day.
They are checking it.
You know what is the incidence of kidney involvement in diabetes, or it is known as diabetic kidney disease? On the day of diagnosing type 2 diabetes is 60%. Because kidney gets affected at least 5 years to 6 years before you develop type 2 diabetes. And that is what is a CKM or metabolic syndrome.
So, you're saying that if a person has diabetes or is diagnosed with diabetes, most of the times the kidney has already been damaged.
Yes. 60% time. That maybe you are diagnosing type 2 diabetes late. That is a possibility.
That is a possibility, yeah.
Yeah. But what I mean to say, kidney gets affected before you diagnose type 2 diabetes. So, whenever you means my advice to the audience, I beg your pardon if I am offending, but if you detect to have type 2 diabetes, or if your doctor tells you that you are diabetic, simply check urine protein loss and the creatinine and GFR.
Okay.
Whether your kidney is affected or not. Because remember, initial stages of this kidney disease, chronic kidney disease in diabetes is reversible.
That is exactly what I was going to ask you, because in the initial stages, there must be some way in which we can prevent further damage or, in fact, reverse the damage.
We'll just go little bit in deep about the CKD staging. Basically, as I told you, there are 5 stages of CKD. Now, stage 1, where GFR is more than 90.
Okay.
90 is taken as normal. But GFR more than 90, but there has to be structural abnormality presence.
Okay.
Like presence of protein in the urine, blood in the urine or pus in the urine, which remains for 3 months.
Okay.
Got it? Or if scar is there or kidney is small, then it confirms as a stage 1. Now GFR between 90 to 60 is made for the geriatric population. All the geriatric people will land up as with the diagnosis of CKD.
Right.
So GFR between 60 to 90 and structural damage, then it becomes CKD stage 2.
So as the person ages, we give them a little space that, okay, even if your GFR is not above 90, that's all right. It needs to be
Around 90 or between 60
60
to
to
90,
90.
it is normal.
because your age is more.
Yeah.
So your kidney will function accordingly.
And there are no signs of structural damage. So we don't call it as a CKD.
And that is, when we say elderly, that is above what age?
Oh, you can't define that way, but elderly is taken as 60 and 65 above.
60 above. Okay.
Yes.
Okay.
Now, coming to cutoff limit of the GFR is 60. If GFR remains below 60 for 3 months, it's an independent criteria for diagnosing CKD.
Okay.
Now, you don't have any structural damage. No proteins, no pus, no blood, no scars, kidney is normal, but GFR is remaining below 60 for 3
And
months.
that is enough for you to say that the kidney is getting some damage.
And the classical example would be diabetes.
That happens a lot in diabetes.
No, not lot. It can happen in diabetes because diabetes, you hardly get any kidney damage structural form except proteinuria.
Okay.
Sometimes proteinuria may not be there. Okay. But GFR is below 60 and history of diabetes. He becomes CKD or diabetic kidney disease. Now, differentiate between CKD and diabetic kidney disease. It is one and the same thing. Only thing is that the etiology is diabetes. So, to diagnose diabetic kidney disease, criteria should be abnormal protein in the urine which remains for more than 3 months or GFR less than 60 which remains for more than 3 months.
And how often are these tests supposed to be done?
Well, on the day of when you diagnose type 2 diabetes, if it is normal, then you repeat first test after 6 months.
Okay, but
And then yearly.
But then, sir, if the kidney function is deranged and we have to check whether it is deranged for 3 months, don't we have to do it like after every week?
See, what you ask me is if or when to be done. I said on the day of diagnosing type 2 diabetes. If that day kidney function is normal, you don't have to do it again. You
Yeah.
have to do it after 6 months.
And if it is abnormal?
If it is abnormal after 6 months. After 6 months, or you mean to say that time only?
That time only if it is abnormal.
You have to take action immediately.
So once the action is taken, then when do you check the kidney to see whether it is improving?
Naturally, if it is positive, ideal way is to repeat the test 2 more times in the course of next 6 months.
Okay.
Okay? To confirm whether it is diabetic kidney disease or not. But do you think the doctor keeps quiet at that moment? No, he's already swung into action. So necessary precautions are already taken. Whether you confirm it or you don't confirm it.
Okay.
That is what I was referring to reversibility. See, initially the functional damage is protein loss most of the time. And that is defined as normal. When the ratio below 10 is normal, 10 to 30 is micro, 30 to 300 is macro, and more than that is severe. Or nowadays it's taken as A1, A2. Anyway, we won't go into the scientific details. But as per doctor or as per the lab report, albuminuria, what comes in UACR report, that is abnormal.
Okay.
At that stage, what is the amount which decides the factor of reversibility? If it is a milder form, there are pretty high chances that it will revert back. For example, the recently published scientific studies from our field related to the very novel drug which has gained immense importance in the treatment of not only kidney, heart, but even strokes. That is SGLT2 inhibitor. That data is clearly shown when you put patient on that medicine for any reason, especially for diabetes, to control the sugar, that reverses kidney damage.
Okay.
Means, for example, there are three categories of proteinuria: normal, then micro and macro. So people have turned back from macro to micro, micro to normal also.
Okay.
So that is reversibility.
Okay.
So the mantra is start a treatment the day you diagnose.
Start action immediately.
Yes, don't keep on waiting to confirm the diagnosis. Because if you go too theoretically, you are going to be a loser. And do you want me to go into the details, how to reverse it and all that? I think that will be too much beyond the scope of this particular episode.
So basically, whatever treatment your physician starts, you have to take your medicines on time, continue the treatment, and that will hopefully make the necessary changes in your lifestyle, and that will hopefully reverse the damage that has been done.
Believe in your physician and follow his instruction. Simple.
Okay.
Because they are going to put you on the recommendation as per the guideline, which will try to reverse the process.
Yeah, because that is important, because usually what happens is, I don't know, correct me if I'm wrong, but in the initial stages, there are not a lot of symptoms.
There are no symptoms at all.
And if the doctor then starts or gives some treatment, the person starts thinking, why am I taking these medicines? Why is it required? I'm not having anything. But I think it is important.
That is doctor's job to explain each and every point. If person doesn't listen, then let him be with
Exactly.
his destiny.
So the thing is, considering the Indian population, we are very treatment averse, or I would say, taking pills regularly in your routine. Maybe we are very averse to that. And when the doctor is telling you that take these medicines, now the damage can be reversed, but it has started. Maybe we don't tend to believe it in the first place. Maybe we are like, no, we'll see about that later. But that should not be done.
The Indian scenario is they are themselves doctor, and to assist them, Dr. Google is there.
Exactly.
That confuses everything.
Exactly.
It's simple example I tell my patients. You're walking on the road, you come across pothole. What your brain says? Avoid it.
Avoid the pothole.
Listen to a doctor. Avoid the pothole. If you want to put your leg in that pothole and get in,
That's
that
your
is your
choice.
choice.
So that is about the kidney function. Coming back to stroke, hypertension as in blood pressure and diabetes, deteriorating kidney function, how quick will it cause a problem in your brain?
See, if you ask me the probability or incidence of a stroke in a kidney patient is pretty high as compared to general population. You can say 1.5 times more. Now why? Because it's a part and parcel of atherosclerotic disease. Kidney, when get affected, first thing is going to affect is this process. That is the reason I told you the death cause or mortality cause in chronic kidney disease, the number one is cardiovascular disease, number two is cerebrovascular accidents. So they are all related to the blood vessel disease, atherosclerosis, because this process hastened up. It takes a speed when kidney gets affected.
Right.
See, there are primary basic factors which causes dyslipidemia, but then there are added factors. Added factor means uremic toxins, then oxidative stress, and then the third one is mineral bone disorder. Now, a little bit specify, take your time. Mineral bone disorder looks very complicated term. No, just try to understand. Your kidney produces active form of vitamin D.
Okay.
What is the function of vitamin D? Absorb calcium from the intestine. Your calcium is required for various cellular processes all over the body. But when your kidney is affected, vitamin D levels are low. If vitamin D is low, there is no calcium absorption. The body function may get hampered. So what body does? It removes calcium from the bone. The bone becomes a brittle kind of thing. During this process, there is a enhancement of atherosclerosis. Okay, so this stage starts in the body when GFR falls below 60.
So these things get accelerated.
So whenever the GFR falls below 60, the acceleration of atherosclerosis is there. So that is the reason incidence of cardiovascular disease or cerebrovascular accidents increases. You're getting my point?
Right.
So when you are treating CKD or diabetic kidney disease, one of the factor of treatment or management is lipids, dyslipidemia. We go as per the guideline. Now, when you take care of the dyslipidemia, naturally the prevention of strokes is also taken care of. But you're asking about particularly related to the blood pressure. Blood pressure, now there is standard protocols. What should be the level of the blood pressure? As per our guideline in nephrology, your systolic blood pressure should be below 120.
Below 120.
Yes, systolic, the upper one.
So when
And that is to be measured only by a doctor in proper way. That is known as standardized office blood pressure measurement.
standardized office blood pressure measurement.
That means in the doctor's clinic, doctor will measure it.
Okay.
If you are measured by that, then the target is below 120.
Okay.
So, if you being it blood pressure below 120, it's going to prevent this as well as this complication, means brain as well as heart complications. So, apart from lipids, the blood pressure control. But why you are specific about the hypertension? Because most of the time, diabetes and hypertension goes hand in hand. Or as I told you, number one cause of CKD is diabetes. Second is hypertension. But hardly we find a patient who you can segregate or separate it out. These are diabetic and these are hypertensive. Most of them go. So management is going to be same. When diabetes is there has to be addition of management of the glycemia, hyperglycemia, means sugar management, apart from the blood pressure control. But recently, the guidelines are pointing fingers towards one particular entity, that is SGLT2 inhibitor, that is brought into the treatment, whether by diabetologist for a sugar management, cardiologist for heart management, or nephrologist for the kidney management. So this has become a common factor. One more new molecule has come, finerenone, which is recommended in diabetic kidney disease only. Not in all the cases, but diabetic kidney disease, again to prevent neurological complications or cardiac complications. So in short, when we manage chronic kidney disease patient to prevent stroke, you need to manage all the factors. You can't concentrate or focus on one particular thing. So
Right.
management of heart or management of brain, that is strokes and cardiovascular disease, is almost same. Apart from the treatment to be given or allocated when incident takes place.
Right.
Like for AMI or a stroke. When stroke takes place, the management is going to be a little bit different from kidney, heart and whatever it is. But for prevention protocol, it is almost same. There is no difference. You need to take care, boss. Just because he is a CKD patient, that doesn't mean that you have to neglect brain. You need to think about that. Because they are interlinked through one or other process. So CKD importance is given equal to cardiovascular disease for the prevention of stroke.
And sir, when you said blood, when you told the criteria about blood pressure, that it should be less than 120. whenever blood pressure is taken, we usually see something which is written above, and then there comes a slash and something which is written below. Right. So, which one is more important? If we had to pick one for the viewers, which one is more important, or both are important?
It is both the parameters are important. For a diagnosis, you need systolic as well as diastolic. But why immense importance is given to systolic in CKD management?
So, systolic is the one which is written above.
Upper one.
Right.
Is because it has shown that if you bring systolic blood pressure at that particular level, the complications are less, cardiovascular and stroke. Okay, so in that way, yes, it has been given immense importance to the systolic blood pressure. There is another factor which is known as pulse pressure, the difference between systolic and the diastolic. That has to be maintained around 30-40.
Okay.
Okay, wide pulse pressure will create more problems.
Okay.
So you have to be cautious.
And it shouldn't even be too narrow. Is that the
hardly
thing?
it remains too narrow.
That never happens.
Wide gap is always there. Because systolic represents, or upper one, represents the status of the blood vessel, softness, pliability. The harder it becomes, higher it becomes systolic blood pressure. And the harder it becomes, it indicates this is the brain and heart is going to go.
Right. So, whenever blood pressure is measured, when we say systolic and when we say diastolic, so systolic pressure has got that name because when we are measuring systolic pressure, we are measuring the maximum pressure that has been exerted to the arteries.
Artery wall, means
Artery
vessel wall.
Vessel
Yes.
wall. And diastolic is the minimum pressure
Yes.
which has been recorded.
Yes. Diastolic is basically end one. Means very difficult to put it in layman's language, but systole is once heart
When the heart
blood,
pumps.
and the blood flows, gushes out to the vessel, to the blood vessel, and the amount of pressure it exerts on the wall is the systole.
At that time is called a systole.
Yeah. And the end one, when heart goes into diastole.
Relaxes. And when the heart relaxes, at that time, whatever the pressure is exerted on the arteries, on the blood vessels, that is
When your diastolic is more than 90, it kind of indicates your blood vessels are still stiff. They are not relaxed.
Right. Sir, we talked about end stage renal disease when the patient needs to go for dialysis. So, how often does a patient like that end up having a stroke?
Now, the stroke incidence suddenly increases when patient goes on dialysis or stage 5 of CKD or end stage, because there is a variability in the blood pressure, higher amount of uremic toxins, and very high chances of atrial fibrillation. Plus variability in the anticoagulants, like we give heparin on dialysis, all that. So incidence is very high. The patient who goes on dialysis, particularly initial first or second month of dialysis, where body is not yet adapted to the dialysis procedure. So that time the incidence is very high.
Okay.
And see, that topic is not so well studied with the scientific data, but as per the incidence with the small studies, it says that these are the factors which are responsible for increased amount of stroke during the dialysis process or in CKD patient. Now, is there any different protocol? Well, you are already taken care of the strokes with the help of antiplatelet agents, controlling lipids and all that. So that protocol is same.
Okay.
But treatment given when stroke is there, I think they are still following the same protocol. There is no difference. Like going for a anticoagulation, well, that depends on the creatinine level and APTT level. Now, these levels are disturbed in any kidney patient. So, depending on that particular level, time, because on an average, this is if you treat stroke, ischemic stroke, with the thrombolysis, in first 4.5 hours, the results are great and reversibility is there. As per one of the data, it shows these dialysis patients are the most neglected patient. They will never report to the casualty with the stroke as compared to general population. Why that? There is no reason. Even though they are the patients who comes frequently to the hospital for dialysis, at least 3 times a week. But still, this is a UK study which has shown that the reporting of dialysis patient for the stroke is always delayed by a day.
Okay, that is strange. When the chances of having a stroke when the person is on dialysis is so high, maybe we should
See,
be more.
patient is in house like going on dialysis, gets a stroke, you can immediately take action within 5 minutes. 10 minutes. But at home,
But at home,
I don't know why they are neglected or why patient neglect himself. He always feel there's something wrong with my dialysis today. So
Okay.
feeling weakness and he neglects the symptoms of stroke. By the time he realizes the day has passed.
so guys, if the patient is on dialysis, the chances of stroke increases.
When we are in doubt, just report to casualty.
Just report to the casualty. Don't wait for anything. Just go to the hospital. Right. So, thank you, sir. Thank you for telling us so many things about how kidney plays such an important role in managing stroke, as in, an important role, because when your kidney is protected, you're protected from stroke, you're protected from any heart attack. And what role what role kidney plays in avoiding all these bad things which might happen. So thank you so much.
Thank you, Dr. Aditya, and thanks to Dr. Ashok Khande. I am honored for the invite. Thank you so much.
Thank you, sir.